Good afternoon, ladies and gentlemen. I'd like to thank the organizers and the office bearers of the SGI, Dr. Matthew Philip, Dr. Vinay, Sandeep Laktakia, Rajesh Puri, and others for giving me this opportunity to talk about pancreatic fluid collections, the use of plastic stents. So before I actually go to the technical tips and when to put plastic stent, we all need to understand that the treatment of fluid collections depends on many things. It depends on whether a patient is stable or has organ failure. It depends on the timing of presentation of the patient. It depends whether there is necrotic debris inside or it's a necrotizing pancreatitis or not, and whether there is infection or not. So before you start considering drainage of a patient, we have to consider all these factors. Now, quickly for the postgraduates, how do fluid collections and necrosis evolve? And this is the revised Atlanta classification. We all know that, but good to revise it again. Interstitial pancreatitis usually results in acute peripancreatic fluid collections, and in necrotizing pancreatitis, you have acute necrotic collections. And most of the acute pancreatic fluid collections resolve without any necrosis. Some may persist at pseudocyst, while acute necrotic collections usually persist and develop later into a world of necrosis, which may be sterile or infected. In some patients, at the stage of acute necrotic collection, they may get infected, what is classically known as infected pancreatic necrosis. So I think this scheme of things has to be kept in mind before we start contemplating draining of a fluid collection. These are some of the examples of acute necrotic collection, infected collections. And this is an example of a classical pseudocyst where there is hardly any necrotic debris. This is a T2 weighted image, MRI image of a patient who had a large fluid collection, and all white areas are seen, suggestive of pseudocyst. On the other hand, another T2 weighted image of a patient with white fluid, and this black is a necrotic debris. So this is how you can say whether it's a pseudocyst or a walled off necrosis. And this can also be easily seen on abdominal ultrasound and surely on endoscopic ultrasound that there is necrotic debris or not. So what should we know before we decide to drain a collection? One, are we draining a pseudocyst or we are draining a walled off necrosis? And if you're draining a walled off necrosis, how much is the solid debris, solid content inside this fluid collection? Are we draining sterile collections or infected collections? Because strategy might differ between these two. Then, is the underlying disease acute pancreatitis or is it chronic pancreatitis? Because in chronic pancreatitis, there is hardly any necrosis you'll see. It's all basically fluid collection because the pancreatic duct is communicating with the collection, and most of these patients require transpapillary drainage as well. Then whom are you draining? Is the stable patient who has come to you after 3 months of illness only with a large fluid collection, or you are dealing with a patient who is in the 4th week, 5th week of illness, still has got active ongoing inflammation and sometimes even organ dysfunction. Then after considering these factors, should we really drain? And we need to understand presence of a fluid collection by itself is not an indication for drainage. So indications are a patient is symptomatic with pain, obstruction, or infection. Or you find on serial follow-up that the cyst is enlarging in size. So that could be an indication for drainage of the fluid collection here. So the prerequisites, these are not technical tips, that prerequisites are usually after 4 weeks. Longer, the better. Longer, the better means if patient is doing well, not much symptomatic, and you can wait for 2, 3, 4 weeks, it is better because the wall will get matured. And you have to have a suitable location of the collection. For example, here, it's a very nice large walled off necrosis in the lesser sac. You can see indenting on the posterior wall of the stomach. But here there is a collection which is much away from the stomach and duodenum, so we can't do endoscopic drainage in such a patient. Of course, there should be an absence of pseudoaneurysm, and most of the time I would advise that before you plan drainage endoscopically, you should do a contrast enhanced CT scan a couple of days before the planned procedure. These are the usual accessories which are required for plastic stent placement. You need to a 19G needle, a long wire, 6 French cystotome, CRE balloon, stent introducer system, and usually 1 or 2 stents. 7 and 10 French, double pigtail, not straight stents. Now, in terms of technique, I'll just like to emphasize a couple of points. What should be your scope position? What is the usual angle of entry? And most important to my mind is stable position of the endoscopist. So usually, most of the time, it should be a short, straight position of the scope, and you should be looking towards the spine. That means you have to turn yourself to the right, and your scope position should be, this transducer should be facing towards the spine. That you know you are draining a posteriorly placed cyst in the lesser sac and not an interior cyst. For example, this is a patient, this is stomach here, this is an MRI image. A large fluid collection is present, which is in the indenting the anterior wall of the stomach. It is in the subhepatic location. And my advice is to avoid drainage of such collections endoscopically, because if there is a leakage, this will lead to peritonitis in these patients. In posteriorly placed lesser sac collections, there is no risk of peritonitis, because even if there is leakage, most of the time it will be okay. The angle of entry, one point I would like to emphasize for the beginners, that you know when you do with the echo endoscope here, this is the angle of entry, which is here. If you see, this is an acute angle, or here it is an obtuse angle here. Now, after you place a stent, after some time you want to go in again, because either you have to do a lavage or a necrosectomy, and you go with a side wing endoscope. Now your angle of entry changes because the cyst is much less in size, smaller in size, and the vision here with side wing endoscope is much different from the echo endoscope. And often you will find that if you have placed a plastic stent, you go with a side wing endoscope, you cannot get entry. It is rather difficult. So this is because of the difference in the angle of entry in the first and the second position. More important is that once you have identified the cyst and you have now planned to drain it, you have to first see that there are no intervening vessels here. For example, you can see here, there's a cyst here, and there are blood vessels between the stomach wall and the cyst wall. So you have to avoid those areas. And then you find that yes, now there is no intervening vessel here. This is the place you can, which is very close, less than 1 or 2 millimeters, 3 millimeters from the stomach wall. You just puncture with a 19G needle here. Once you have punctured it, then you put in a wire, make at least 2 loops with your wire, and after that you remove your needle and put a 6 French cystotome like this to dilate this. Now this helps in easy passage of a CRE balloon. So my advice would be that you use a 6 French cystotome for dilating the tract here. And after that, you remove the cystotome, put in a CRE balloon and over this wire. And once your CRE balloon is inside the cyst, now there are 2 options. Option 1, that you dilate with the CRE balloon under EUS vision, or now you withdraw the scope a little bit, put the up wheel down, and under vision, you see that your CRE balloon is now well placed. And now you can dilate under vision to 12 to 15 millimeters in the first go itself. So this depends on the endoscopist, whether you want to dilate with a CRE balloon while you are inside under EUS vision, or what I'm showing here, that you actually withdraw your scope and under endoscopic vision, you dilate like we used to do earlier when we were doing direct endoscopic drainage under endoscopic vision rather than EUS guided. Now, after you have dilated, then you can, place a stent introducer set, and you want to place the stent. Now, here I want the attention of the residents here. You see the stent is being placed. This is the first black mark which has gone in. Now, the moment the first black mark has gone in, now you have to change the position of your scope. So what you do is the up and down wheel should be down. You withdraw the scope a little bit and open your elevator. That's important. You see here, open the elevator. This will change the entry angle of the entry of the force of the stent. So the force you're applying on the stent will be changed. the angle will change. And then you push the stent out into the stomach. This will avoid internal migration of the stent, which is often a problem when you place a plastic stent. Now, the next issue is, and I'm sure there is a next talk on metal stent, and the next person will talk about this, but I just want to tell you what are the indications where plastic stent is a very good stent. So in chronic pancreatitis with pseudocyst, plastic stent should be put in. There's no reason to put a metal stent because there is hardly any necrosis there. Most of these patients would require a transpapillary PD stenting because the cause of a pseudocyst is leakage and stricture in the pancreatic duct. That is why these patients require pancreatic endoscopic therapy. In acute pancreatitis pseudocyst, again, plastic stents are good enough. You can place 7 to 10, usually two French stents. So this was the first randomized trial between surgery and endoscopic, published many years ago by Shyam Bardrajulu, and he showed even with the use of plastic stents, these were better than surgery or similar to surgery in terms of success and complications. Now, the only thing is in this trial, most of the patients had chronic pancreatitis with fluid collections. Hospital stay and cost was less endoscopy. So we performed a randomized trial between laparoscopic drainage and endoscopic EUS guided drainage in patients with acute pancreatitis. This was published about three years ago. And in a study of 60 patients, we found that successful drainage, overall successful outcome were similar between the two groups. So was the hospital stay and need for other interventions. The only difference between the two groups was that in the endoscopy group, because we had placed plastic stents, the incidence of post-operative infection, secondary infection of these walled off necrosis was seen in about 60% of cases. And these patients required repeat procedure with endoscopic lavage and necrosectomy. Now, some would argue that this is a standard procedure for when you do endoscopic drainage. That means you do drainage if patient has fever or has infected necrosis, you have to go in after 2 to 3 days, do a lavage, and if required, do a necrosectomy. So this should not be taken as a complication. This is actually part of the procedure. But because we realized in this study that placing a plastic stent in those who had larger amount of necrosis resulted in more infection, we conducted another trial. And in this trial, what we did was we tailored our approach in the endoscopic group.
Dr. Pramod, we have, sorry to disturb, another last 2 minutes.
No, I'll take another couple of minutes. Yeah, 3-4 minutes. So if the debris was less than 1/3 of the cavity, we placed 2 plastic stents. And if the debris was more than 1/3, we placed a metal stent. And this was the endoscopic group, and we compared it with a laparoscopic drainage group. This study was recently published, and we found that the successful drainage was similar in 2 groups, and so was the need for additional procedures between the 2 groups, no difference. What was different was the duration of hospitalization and the procedure time were much smaller, shorter in the endoscopic group compared to laparoscopic group. In infected necrosis, we all know about these 2 trials, tension and Miser trials, which compared endoscopic with the laparoscopic or Ward group. In both these studies, they showed endoscopic drainage is as good as surgical drainage. And in both the trials, plastic stents were used and not metal stents, even in the case of infected necrosis. And in case you have secondary infection, as I said, endoscopic step therapy should be done. So, ladies and gentlemen, I'd like to summarize by saying that in pancreatic fluid collections, EUS guided drainage is the preferred if it is indicated. We should try and avoid anteriorly placed collections. In the technique, I think most of you know about technique. The only thing I would emphasize is once you have punctured the cyst, don't move at all. Don't move yourself, don't move your scope till you have dilated the tract. That's important. For pseudocyst in walled off necrosis less than 30%, I would strongly recommend placing a plastic stent. And those who have 30%, more than 30% debris or infected necrosis, I think a metal stent might be better. I'm not sure it is better, but might be better. Thank you for your kind attention.